Good afternoon everyone. Today topic of presentation is on statin intolerance. NLA scientific statement on statin intolerance is the definition of statin intolerance is one or more adverse effect associated with statin therapy which was resolved or improves with dose reduction or discontinuation of therapy. Two type of statin intolerance seen: complete intolerance, partial intolerance. Complete intolerance means inability to tolerate any dose of statin. Partial intolerance means inability to tolerate the dose of necessary to achieve the patient specific therapeutic objective. For diagnosis of statin intolerance, a minimum 2 statins should be attempted, including at least one at lowest approved daily dosage. Statin affecting HMG-CoA pathway is essential for cholesterol formation, phenylated protein for membrane stabilization, and mitochondrial function. Due to statin drug, it cause dysfunction of mitochondria and membrane, which lead to myopathy, myalgia, neurological side effect, liver dysfunction, which lead to statin intolerance. In muscle, statin concentration increases, which lead to mitochondrial dysfunction, which lead to damage to the muscle membrane, which lead to rhabdomyolysis, myalgia, and myopathy. Predisposing factor for the statin intolerance are older age more than 80 years, female sex, low BMI, Asian ethnicity, family history of myopathy, severe renal disease, impaired hepatic disease, hypothyroidism, diabetes mellitus, and genetic polymorphism of P460. Other modifiable factor associated with statin intolerance are high statin dose, high alcohol intake, excess of alcohol intake and grape juice, illicit drug use, heavy exercise, vitamin D deficiency, and other drugs which are increasing statin dose. TSH more than 10 and TSH 4 to 10 requires thyroxine substitution for at least 3 months. After that, lipid profile is done, and if residual dyslipidemia is present, then statin therapy is initiated. Incidence of statin intolerance are more with overall prevalence is 9.1%, more in female and more in age more than 65 years. The statin therapy lead to muscle symptoms like myalgia, myopathy, rhabdomyolysis, liver side effect raised in enzyme SGPT, SGOT, and dysglycemia. There is increase in HbA1c, a patient who are on rosuvastatin therapy in Jupiter trial. Classification of statin related muscle toxicity, SRM. SRM 6 types are defined. SRM 0 means creatinine CK elevation more than 5%, less than 5% of upper normal limit. Incidence is 1.5 to 2%. No muscle symptoms. In SRM 1 there is myalgia and tolerable muscle symptoms. In SRM 2 myalgia is intolerable and muscle symptoms without CK elevation in SRM 1. In SRM 2 myalgia intolerable with CK elevation less than 4 times of upper limit of normal. In SRM 3 there is myopathy, CK elevation is more than 4 times but less than 10 times. Muscle symptoms complete resolution on D challenge. SRM 4 is severe myopathy, CK elevation is more than 10% of upper limit of normal and less than 15%. Muscle symptoms complete resolution of symptoms on stopping the statin therapy. SRM 5 is rhabdomyolysis, CK elevation more than 10%, evidence of renal impairment, muscle symptoms or CK elevation more than 15%. SRM 6 is autoimmune mediated necrotizing myositis. It is a detection of HMGR antibodies expression in muscle which showing autoimmune myositis and incomplete resolution on D challenge. In SRM induced necrotizing autoimmune myositis should be suspected in patient with progressive muscle weakness and ongoing CK elevation despite of statin withdrawal. Requires immunosuppressive treatment and re-exposure to statin. Reassess the need for lipid lowering therapy. May be eligible for treatment with PCSK9 inhibitor. Statin associated muscle symptoms. In statin associated muscle symptoms, there is regional distribution of muscle symptoms like location and pattern of muscle symptoms, temporal pattern, de-challenge, re-challenge, statin myalgia clinical index score. In regional distribution of statin induced myopathy is include symmetric hip flexure and thigh ache, symmetric calf ache, symmetric upper proximal ache, non-specific asymmetrical intermittent. Temporal pattern, timing of muscle symptoms. Symptoms onset less than 4 week, symptom onset 4 to 12 week and symptom onset less than 12 week. D-challenge, improve upon withdrawal less than 2 week, improve upon withdrawal 2 to 4 weeks and doesn't improve upon withdrawal more than 4 weeks. Re-challenge, statin symptoms reoccur upon re-challenge less than 4 weeks, statin symptoms occur upon re-challenge in 4 to 12 weeks. Statin myalgia clinical, above these symptoms we calculate statin myalgia clinical index score. If it is 9 to 11, there is a probable chance of statin related toxicity 7 to 5. There is possible chances and less than 7 unlikely. Statin associated muscle symptoms are more likely if present bilaterally, including large group of muscle, thigh, buttock, calves, shoulder and girdle muscle ache, weakness, soreness and stiffness, cramping, tenderness and generalized fatigue. Timing of symptoms, onset of symptoms 4 to 6 weeks after statin initiation, onset after statin dosage increases. Other consideration, medication or food interaction, high dose statin therapy, history of myopathy with other lipid modifying medication, regular physical activity, impaired hepatic and renal functions, substance abuse like alcohol, cocaine, female, elevated CK level more than 4 times or more than 10 times, sense more likely. There is various group of statins including lovastatin, simvastatin, pravastatin, fluvastatin, atorvastatin, rosuvastatin and pitavastatin. Pravastatin, fluvastatin, rosuvastatin and pitavastatin are hydrophilic drug, so there is less chance of myopathy in this drug. Lipophilic statin and lipophilic statin metabolized through cytochrome 450 produce more statin intolerance. All statin undergo hepatic metabolism. Pravastatin and rosuvastatin has additional renal metabolism. There is a primo study of statin intolerance in which atorvastatin and simvastatin has more muscle symptoms than pitavastatin and fluvastatin. Statin related hepatotoxicity seen in 2% of patient. Asymptomatic increase of aminotransferase more than 2 times of upper limit normal is seen in a patient with statin therapy, which improve with dose reduction and not associated with any increase in bilirubin level. If aminotransferase elevation is associated with increase in bilirubin level, statin discontinuation must be done. And other side effects include hepatitis, acute liver failure. In patient with chronic liver failure, non-alcoholic steatohepatitis, primary biliary cirrhosis, liver function test should be done, although those patients are no longer risk of hepatotoxicity if enzymes are not increasing. Statin therapy is safe in non-alcoholic steatohepatitis to reduce the risk of further cirrhosis and hepatocellular carcinoma. Atorvastatin is most implicated for hepatotoxicity, and then simvastatin, fluvastatin, pravastatin and rosuvastatin has least hepatotoxicity. So in patient with liver disease we can use rosuvastatin, and the prospective study shows that the symptom of statin induced hepatotoxicity 80% due to hepatocellular injury, cholestatic and mixed injury seen with atorvastatin, drug induced autoimmune hepatitis seen with atorvastatin, similar clinical, biochemical and histological parameters as drug induced autoimmune hepatitis. FDA one hepatotoxicity seen with statin is 1 per 1 million. Acute fulminant liver failure is seen. Merck worldwide adverse database shown 1 per 1.4 million patient liver failure, and 0.1% of 23,000 patient with severe transaminitis. New onset type 2 diabetes mellitus with statin treatment seen with high body mass index, impaired fasting glucose, elevated HbA1c, older patient and high dose of statin. Statin intolerance which lead to increased insulin secretion and decrease insulin secretion and decrease insulin sensitivity, which lead to type 2 diabetes mellitus. Incidence of diabetes rate is greater with high versus moderate or low potency statins. Pravastatin, high potency atorvastatin and rosuvastatin has highest incidence of increase in HbA1c, and simvastatin moderate potency is increasing 26% of HbA1c, and low potency fluvastatin and lovastatin is 21% increase in HbA1c. High intensity statin means statin which decreases the LDL cholesterol by more than 15%. Moderate intensity statin means lowers the LDL-C by 30 to 50%, and low intensity statin means decrease the LDL-C by less than 30%. High intensity statin include atorvastatin 40 mg and rosuvastatin 20 mg to 40 mg. Moderate intensity statin include atorvastatin 10 mg to 20 mg, rosuvastatin 5 mg to 10 mg, simvastatin 20 mg to 40 mg, pravastatin 40 to 80 mg, lovastatin 40 mg, fluvastatin 40 mg twice daily, pitavastatin 2 to 4 mg. Low intensity statin lowers the LDL-C by less than 30%. Simvastatin 10 mg, pravastatin 10 mg to 20 mg, lovastatin 20 mg, fluvastatin 20 mg to 40 mg, and pitavastatin 1 mg. Benefit of statin treatment exceeds the risk of type 2 diabetes mellitus. So, treatment with 1000 patients for 5 years with 40 mg atorvastatin daily yield the 50 to 100 case of new onset type 2 diabetes mellitus, which overweighs the medical effect of statin on cardiovascular disease even among high risk patients and those involves who have diabetes mellitus. So, patient is treated with statin therapy if high risk of cardiovascular risk present. Statin clinical studies which shows the statin induced diabetes mellitus is Jupiter trial and CARD study. In Jupiter trial, the risk factor of diabetes in the patient with 20 mg rosuvastatins were increased the risk of 28% of developing diabetes mellitus despite of reduction in LDL-C level and cardiovascular events and mortality. And in this CARD study, the atorvastatin 10 mg increases the significantly glycemia progression in patient with diabetes mellitus patient and did not increase the duration and risk reduction. Neurological side effect with statin intolerance include hemorrhagic stroke, cognitive decline, peripheral neuropathy, depression, confusion, memory loss. Mechanism of statin intolerance include direct statin damage the blood-brain barrier, which cause direct toxicity of neurons and which lead to this mechanism. Low hemorrhagic stroke, low cholesterol in people with hypertension, sparkle trial, stroke prevention by aggressive cholesterol reduction, reduction in ischemic stroke but increases the hemorrhagic stroke. Treatment of 1000 patients for 5 years with effective would lead to 5 to 10 cases of hemorrhagic stroke. Statin induced psychiatric effect, aggression, agitation, irritability, mood changes, sleep disturbance, and highest incidence of depression is seen with simvastatin. Nocebo effect is statin toxicity, all in mind. Sometimes patient have in mind that I have started statin, so I have myalgia, myopathy. Actually, there is statin cause symptoms, but it's not from statin, it's from taking the statin tablet. It's called nocebo effect. This one study is done in patient taking no placebo. There is 15% symptoms, no treatment 8%, on statin 16%. So sometimes patient have insignificant complaints. So we have to rule out such a risk. Statin benefits are more, so out of this side effect we have to continue statin despite of patient on high CV mortality risk. Prospective meta-analysis of 19,000 participants in 14 randomized statin trials. The benefits of statins are well established. Benefits are more and versus known fact, higher intensity statins are better for reduction in LDL-C cholesterol. Intensive statin therapy decrease LDL-C to of 0.5 to 1 millimole per liter, 16% reduction in ischemic stroke and 13% reduction in coronary death and non-fatal MI. So statin are more powerful, so we have to individualize the treatment according to the patient's symptoms. Effect on CV risk relate 1 millimole reduction in LDL-C cholesterol. After decreasing the 1 millimole of LDL-C cholesterol, there is major decrease in major coronary event, decrease in any coronary revascularization, any stroke, and there is major decrease in cardiovascular mortality and morbidity. So statin drug must be continued. Absolute benefit of statin: secondary prevention, decrease in major coronary event, stroke and major coronary revascularization due to statin therapy. 2022 recommendation for initiation of statin therapy. If patient demonstrating non-adherence or lack of persistence with statin therapy, statin intolerance should be considered the contributing factor. For patient with suspected statin intolerance, clinician should be attempt multiple strategies to identify tolerable statin regimen, lower dose, switching statin, non-daily dosing, because complex statin complete statin intolerance is uncommon. Less than 5% of patients when non-statin therapy are used, dosed with the data from randomized trials showing reduced cardiovascular risk should be favored. Patient with known or suspected statin intolerance who are at high or very high ASVD risk, non-statin therapy should be considered with additional attempts to made to identify the tolerable statin regimen to avoid excessive delay in lowering atherogenic properties. For patient with statin intolerance, it is responsible to consider the nocebo effect as possible as cause. However, this dose doesn't make such symptoms less clinically elevated, and ASVD risk related to elevated atherogenic should be addressed. Patient with statin intolerance present to you, how to approach: measure the CK level, creatinine kinase level and symptoms, assess symptoms according to we previously discussed symptom score. Intolerable symptoms: if patient creatinine kinase clinical concern and creatinine kinase levels are more than 4 times of upper limit of normal and less than 10%, stop the statin therapy for 4 to 6 weeks. Document the symptoms. Creatinine kinase normalize, have symptoms related to statin intolerance, stop the statin therapy or decrease the dose of statin, atorvastatin 10 to 20 mg or rosuvastatin 5 mg. If recurrence of symptoms occur, consider other option like azatimib, bempedoic acid and another option. If creatinine kinase more than 10 times of upper limit of normal, more than and renal dysfunction present, stop statin therapy immediately and consider another treatment, and never restart the statin again. If patient having tolerable symptoms and no clinical concern, creatinine kinase level less than 4%, improvement within 2 weeks, patient start therapy or decrease the dose, patient can continue on statin therapy. Adopt person-centered approach. Therapy with lower dose of statin is preferred. Apply de-challenge, re-challenge to know that symptoms are caused by statin. Switch to different statin or re-challenge with lower dose of statin. Patients who do not tolerate statins on daily dose, alternate days dosing is good option. Rosuvastatin and atorvastatin have longer half-life, so can use as a alternate day regimen. Adding azatimib to lower dose statin may cause reduction in LDL-C, and once the new regimen tolerated and achieve the LDL and HDL-C goal with minimum dose of statin. De-challenge, re-challenge. How to do de-challenge and re-challenge: stop the statin and allow 2 week without 2 week washout period. Restart same statin at lower dose or different statin, switching to statin that is metabolized by different pathway. Unable to tolerate atorvastatin, lipophilic, primarily cleared by the liver. Rosuvastatin, hydrophilic, cleared by the kidney and liver. If patient failed daily statin, try intermittent dosing with an extended half-life, rosuvastatin, atorvastatin, pitavastatin once a week or increase every 1 to 2 weeks. Give a patient control over titration and schedule can be helpful. Every other day dosing can be effective in lowering LDLC level. A retrospective study of 51 patients intolerant to statin, 72.5% patient able to tolerate rosuvastatin dose of 5 mg. And mean LDLC decreased 34% in patient who tolerated this regimen. Non-statin alternative which can be used, ezetimibe 10 mg lower the LDL cholesterol by 15 to 20%, can be used with statin or without statin. Bile acid sequestrant reduces the LDLC by more than 50%. Colvesalam 3.75 mg sachets day or 625 mg 6 tablet per day. Ezetimibe plus bile acid sequestrant decreases the LDL cholesterol 34%. Bempedoic acid 180 mg per day can be utilized with ezetimibe. Ezetimibe bempedoic acid combination reduces the LDLC cholesterol decrease 35 to 40%. Pitavastatin 4 mg plus ezetimibe plus bempedoic acid is good affordable combo in patient with statin intolerance. PCSK9 inhibitor evolocumab can be used and inclisiran can be used. Bempedoic acid mechanism of action. Bempedoic acid inhibit the ATP citrate lyase which occur in HMG earlier step in lipid synthesis which before the HMG CoA synthesis inhibitor. So bempedoic acid is a prodrug and which need activated enzyme to work on the LDL pathway, so which was not present in muscle membrane. So muscle related symptoms is not present with bempedoic acid. So we can safely use who patient having myalgia symptoms. Bempedoic acid decrease in LDLC cholesterol 10 to 15% in patient with higher lipid drug. The GOS3 study is evolocumab and comparing ezetimibe. Evolocumab decreases the LDLC 52%. So patient with statin intolerance, we can use alternatively evolocumab drug. And alirocumab also decreases the 45% reduction in LDLC. So adhesive alternative trial emphasis the who patient are statin intolerance, we can use the alirocumab drug. And patient having vitamin D deficiency have more myalgia with statin type of statin class of drug. So we can supplement the vitamin D to reduce the myalgia related symptoms. Who patient are on statin therapy having myalgia, we supplement the vitamin D. There is 35 patient having reduction in myalgia with treatment with vitamin D. So patient with statin intolerance, we have to rule out the cause like hypothyroidism, old age, vitamin D deficiency. We treat that cause or start alternative statin and decrease the dose of statin. We cannot stop statin if there is more than CK level more than 10 times of normal or patient having renal injury, severe metabolic dysfunction. We cannot restart the statin. We then stop the statin and rechallenge protocol, because statin have major role in prevention of cardiovascular disease and has proven trial more than any other drug.